Hello, everybody. Welcome to MHTV. It's really lovely to see you. What we're going to be doing today is talking about diabetes and mental health, which is a really important subject for us to be aware of. We're doing things a little differently tonight, so it's going to be just me on the screen, but Dave is lurking. So please do join in with any questions you've got, any comments that you want to make. It's you that really make this. So do ask questions. If you're on Twitter, use the hashtag MHTV and then field your question. If you're watching on Facebook Live, please just type away there, and Dave will feed the questions into me and we'll ask them. But let's go to our guest now. Fantastic. Thank you so much for your time today, Ruth. Can you tell people a little bit about yourself?
Yes, thank you for inviting me. Yes, I'm a diabetes nurse consultant. I've worked in diabetes for probably the last 20 years, but got a background in working in all sorts of settings across the NHS, really, in the community and in acute.
So let's think about, what is it about diabetes and mental health? How are they together? How are they interrelated? And what's brought you to that?
So first of all, if you've got diabetes, you're much more likely to develop depression. So there's a kind of bidirectional relationship, which is quite complicated. And people who live with diabetes often experience diabetes distress, and it can hugely impact their mental health and their well-being generally. And but then if you look at people who have serious or severe mental illness, they also have a much greater likelihood of developing diabetes. And so what really interests me, because I'll talk a little bit in a minute about training that I've developed, what really interests me is to make sure that people with serious mental illness who already have, experience huge health inequalities, that the sort of ignorance around diabetes is not added to their health inequalities, that there is a much greater understanding of how diabetes impacts people with serious mental illness.
You make a really good, valuable point there, particularly about, the experience of depression for people with any long-term health condition. Yeah. We don't always think to check for those things because we get so hung up in physical health on physical health and in mental health on mental health that we don't think about that bidirectional relationship that you're saying. So what led you to sort of focus on diabetes? How did you get into that area of work?
Good question. It's a fascinating condition. It is inextricably linked with socioeconomic, political stuff. It's not just like all conditions in many ways. I kind of fell into it a little bit, but once I was working as a practice nurse, and I was asked to run the community diabetes clinic, and I learned from the patients that I met. But once I specialised in it, I found it endlessly fascinating and incredibly rewarding as well.
Yeah, absolutely. So, what's the work that you're involved in at the moment? So we'll come back to talk more about diabetes and mental health in a minute, but if you could just tell us a little bit about the work that you're doing at the moment.
So I recently just left a job that I was in as a diabetes nurse consultant in Northwest London, and I'm now working back at an acute hospital as a diabetes specialist nurse, back to nursing, which is what I've really missed doing, just diabetes nursing, seeing patients. But for the last probably 8 years, I've been involved in developing training for frontline staff, diabetes training. And I'll just tell you a little bit about how that came about. So there was a serious untoward incident in a hospital that I was working at. And it was a young woman with type 1 diabetes and schizophrenia, came into A&E, and she was admitted under the mental health team. And she wasn't referred to the diabetes team because it was everything that was happened seemed, appeared to be down to her mental health, this sort of diagnostic overshadowing, really. And ultimately, she died at home. And when we kind of went, I was involved in going to the inquest, it became clear that actually she had been telling staff that she was having hypos. And in fact, if you were to sort of look at what it was that had led to this tragedy, it was literally as simple as, it wasn't a complex medical thing, it was that nobody heard what she was saying. And to me, that was just so, dreadful. And how do you prevent that sort of thing from happening again? And there are a few incidents like that where you sort of carry the patient's faces in your mind's eye, or your client's face in your mind's eye as you go along. And so I was kind of driven to develop basic diabetes training. It's starting with frontline staff. So it became absolutely clear in a hospital, an acute hospital, all over the country and probably internationally as well, that frontline staff don't always understand basic diabetes, and very often it's complex diabetes that is being managed in hospitals. And so that happened. It's called diabetes 10-point training. And then not long afterwards, it became clear that actually all parts of the patient pathway, as I said earlier, you can't discharge somebody home from hospital to a community nursing team if they don't have basic diabetes knowledge, or indeed to a mental health team, whether it was in the community or inpatient mental health team, and or into care homes. And that's so in the last sort of 4, 5, 6 years, I've really focused on developing these training programs. And they've been, I think, successful because they are concise, they're fast, they take about an hour, and because they're highly relevant. So we've all sat through training where we've sort of thought, oh my goodness, how does this relate to what my everyday role is? And so the idea is that it's highly relevant, and hopefully really does impact somebody's everyday working life, that it gives them the tools to be able to help their patients.
Fantastic. And Dave will be putting those links out via Twitter and via Facebook as well. So it's free, open access. You can, wherever you're working at the moment, we would urge you, and we will carry on urging you from time to time throughout this discussion, to check out that resource and actually make sure that your knowledge and understanding is where it needs to be for you to be able to give, and be confident about giving a good standard of care. So if we just cycle back to so many things that you said. So I think the first one is, for anyone who's not aware, you think you could explain what diagnostic overshadowing is?
Well, my understanding of diagnostic overshadowing is where, for example, if you see a patient in a given sort of situation, and I'm sort of thinking about in A&E, for example, and a patient, so in this particular instance, the patient was complaining that she was having hypoglycemia, but all the staff saw was her, severe, her schizophrenia, her severe mental illness. And so my understanding of diagnostic overshadowing, and I might be wrong, and you might want to correct me, is that all you then see is the physical, the mental illness, and you don't actually consider the fact that that individual does have a physical symptom. And we do see this quite a lot in diabetes.
And it's interesting, isn't it? Because it's almost like looking at someone with mental health glasses on. So all you see is the diagnosis, the mental health diagnosis, and then it makes people assume that person is an unreliable witness, which is, again, the kind of stigma. We'll talk about diabetes stigma, but there's always been a problem with staff really listening to people with mental health distress talk about physical illness, be it pain, be it types of symptoms, and just not hearing it because they attribute it to other things like anxiety or confusion.
And I think we do it the other way around. I think it works both ways for people working in physical health, but I also think there's something else to that. I think people with autism, and I didn't want to forget people with autism, learning disability, as well as people with serious mental illness. The sort of way that people experience and report the physical symptoms are going to be different. They're going to be, and I think it's about having that understanding as well. Having an understanding that actually somebody with autism, for example, will need to be trained to be able to tell someone if they've got a physical symptom, may not be able to tell them at all. So it's about us being more observant.
And being curious, isn't it? And getting engaged. But there is, you were saying before, there are some aspects of presentation when someone is suffering a hyper, and that can be confused for other things. I wonder if you could just clarify that.
No, thank you. That's a really important point. So in the training, we talk about it being, so it's a hypo, that is a low blood glucose below 4, or hyperglycemia, which is a sort of blood glucose consistently in double figures. There's no real definition of that. Can the symptoms of both of those can be mistaken for psychiatric symptoms. For example, hypoglycemia, that is low blood glucose. People can become aggressive. They can become disengaged. They may fall asleep and not engage with you. They start snoring loudly, but it's mainly the aggression. And it can result in fitting as well, which is what happened. So what I didn't mention with that particular young lady, she actually presented with a dislocated shoulder, and she'd been fitting. And she had been fitting during her hypos. So that is hypoglycemia. And hyperglycemia, that's high blood glucose. People can become very sleepy, very socially kind of remote. And I can recall a patient who was actually homeless, had stopped injecting his insulin. He had type 2, but his blood glucose was so high, he took to his bed. And he was diagnosed with schizophrenia. My understanding was because of the negative symptoms of, the social symptoms. But actually, when his insulin was reinstated, and it was the understanding that it was actually probably more to do with the fact that his blood glucose was so high. As I recall, they questioned the schizophrenia diagnosis. So that's really kind of
fundamental, isn't it? Yeah, to check that stuff. Absolutely. So I guess there are other presentations as well that can be complicated. So and you were saying how situational, circumstantial, social and political diabetes is. So at the moment, obviously, we're working a lot with people who are very financially restricted, which is making, advice a little bit challenging at times to get it right, to get the pitch and the tone of it right. I wonder if you've got any sort of advice for how staff can start to ask questions and have these sort of discussions about managing diabetes well.
First of all, I mean, you're so right. I mean, so let's just talk about that sort of that inequality for a minute. So certainly diabetes impacts people who are poorer, people from minority ethnic groups. So if you're African, Caribbean, Asian, you have a much increased risk. And there are all sorts of reasons for that. People with learning disabilities, and as you probably know, people with serious mental illness have a hugely magnified risk, and they will develop it about a decade younger, partly because of the antipsychotics. And sometimes there's a question over whether antipsychotics have been given appropriately as well in all cases. And the other thing I wanted to just bring in is that not all managing diabetes is about eating healthily, and so there's a perception that all type 2 diabetes is about being overweight and lazy. Okay, and if only you did something about it, and there's sort of you did it to yourself, and sort of punitive, negative kind of stereotyping of people with diabetes. And I just wanted to add that people with diabetes, all types of diabetes, live with a lot of shame and guilt. Yeah. And that shame and guilt prevents people from self-managing their diabetes. And self-management is a cornerstone of diabetes. So it becomes a hugely important. And I think if you just sort of look at the media and the messages in the media about diabetes, it's all about, using up valuable resources, diabetics who don't look after themselves. And I think so. If there was anything that I would sort of suggest that anyone needs to do is to think about your own attitude towards diabetes. Make sure that when you do, kind of address your patients, or if you're thinking about talking to your patients or your clients with diabetes, think about the words that you use. Don't use words like controlling diabetes or compliance, or even, so where people are sort of non-compliant. And there's a very good document called Language Matters Diabetes, which is talks about all of that. And it's much more about a sort of partnership, trying to sort of understand how people manage their diabetes, given their constraints, or that, it's everybody will manage their diabetes differently, and everybody's diabetes will be different. So diabetes also is different in different ethnic groups, actually. So with regard to foods, you're absolutely right. So, at the moment, we know, especially at the moment, some people can't even afford to eat at all. And some of it is about the carbohydrate. So the cheapest food is usually the starchy food, isn't it? The sort of potato, pasta, bread, rice, cereal. And there's no point in talking to somebody about healthy eating if they're going to depend on food banks And well, it's not that there's no point, it's just going to be much, much more difficult for them.
It's a conversation you have to have with real sensitivity, isn't it?
Yeah.
And I think
and
with any health advice, that's true.
Yes, because it becomes a value judgment. And it becomes, sort of like you're adding to people's sense of self-worth and, lack of self-worth. But, things like if people are able to cook, things like lentils and, that sort of thing, rather than that's the sort of way to go. But it's really, really difficult. And I think it's about being realistic. And also, I think we mentioned this earlier, food is incredibly emotive. People are motivated to eat for all sorts of reasons. It's not just that they're hungry or greedy.
Yeah, I think you're absolutely right. I mean, the emotional component to eating is so important. And I think it kind of leads us into another area, which can be a little tricky for mental health workers as well, which is when you're working with somebody who has diabetes, but also has issues around food, maybe eating disorders, whether they're diagnosed or sort of not specific yet. So I wonder if you have any thoughts or any wise words for us on that.
So type 1 diabetes, especially what people can do, they have the power to do, is if they don't inject their insulin. So type 1 diabetes is a diabetes that is much rarer than type 2. It's about 5 to 10% of all diabetes. And so if you have a patient with a serious mental illness in type 1, you're going to know about them because they're going to run into lots of issues. People with type 1 diabetes need to make multiple decisions all the time, every day, about how much insulin to inject, how much food to eat for that insulin, factor in all of the factors that may. There are 42 factors, by the way, that affect blood glucose, many of which can't be controlled. And there are links on the training about that people aren't aware of. So what people learn from an early stage, if they have type 1 diabetes, especially if they're going through adolescence, and often if they're women, but men as well, that if you don't inject your insulin, you'll lose weight. And you won't just lose weight, you could lose a whole dress size in 1 or 2 days. And so we have this thing, it's been called Diaboliemia, and it's a very serious, very dangerous diabetes condition, eating disorder. And it's hugely complex. Patients with Diaboliemia should be referred to specialist centres. I know King's have got a very good centre. I think they're called, I can't remember what it's called actually, and then there's St Anne's as well in North London, but there are specialist eating disorder centres. I think it's called Tide, the one at King's. And then you have disordered eating, which is slightly different. But yeah, it's hugely important that if somebody with especially type 1 diabetes is getting it horribly wrong and running into trouble, it's not because they don't know what to do, it's because they're struggling. And people do struggle hugely with, and there's something called diabetes distress, and diabetes burnout, which are both sort of recognition, and they are real sort of conditions that people who live with especially type 1 diabetes very often become incredibly distressed about their diabetes and are just not able. They feel that they're not able to carry on, and they do need help.
You just need the slightest bit of empathy, don't you, to imagine how that must be to live with from childhood upwards. For it to affect you, maybe at school, if you had bullying because of it, then you see in the newspapers how people talk about those things. If you have to inject publicly, sometimes that can be an issue for people sticking their nose in. Those sorts of things can be really difficult. It's absolutely understandable. You just get exhausted by it.
Absolutely, and you're absolutely right. It's about sort of if you know anyone with type 1 diabetes, and if they ever talk to you about it, it is just unbelievable. The burden, the huge burden of sort of self-care is absolutely enormous. But also the kind of the fact that people are always telling you off, your family members, maybe your healthcare staff, maybe your GP. What have you done wrong? Why can't you get it right? And we also know diabetes isn't an exact science. So when people are told off and to get it right, they've often tried to do what they've been told, and guess what? They find out it doesn't work, and then they become alienated from the healthcare team and make up their numbers. I probably would.
It's interesting, isn't it? Because this overlaps with lots of different behaviours that sometimes you see in health staff, which is sometimes if you feel frustrated, you get cross with the person who's actually come to you for help, and that's really unhelpful. So it's ever so important, isn't it, for us to think about our own values, our own prejudices, but also our own well-being, so we're not passing on negative feelings to people who are vulnerable, really vulnerable.
Yeah, no, you're right.
Yeah. We've got a couple of questions, if you're okay with that. So just to say, they're coming through now. So thank you and welcome to it's also Jocelyn, Pally, Sophie, Florence, Tendai, all hello to you guys. And Josephine is asking a question. When you refer to basic diabetes, what are we looking out for? So I suppose what's the difference between basic and complex?
Oh, okay. Well, that's actually a good question. Actually, I say basic, but sometimes I think about maybe it isn't that basic. But I guess what I'm saying is making it accessible. Diabetes is complicated, and especially if someone's got a mental illness as well. And so we make it so I'll give you an example. Knowing what a hypo is, knowing how to recognize it, knowing how to treat it. So point number one, for example, is listen to the person. They live with their diabetes 365 days a year, respect the knowledge they have of their own diabetes. Point number two would be about understanding the difference between the types of diabetes. And that, why is that important? It's hugely important because you would never stop insulin in someone with type 1 diabetes because they would probably die if it went on for long enough. And so it's all the sort of nuances in that. So, and that's point two. Point three would be about checking feet, knowing about the sort of understanding the importance of escalating any concerns that you have if someone has a problem with their feet. 4 is how to recognize and treat hypoglycemia, how they can be mistaken for psychiatric symptoms. 5 is the same, but for hyperglycemia. And I think I missed out one in this, which is diabetes and mental illness, and the impact of antipsychotics. And so it goes on. There are a few more others, but that is basic. So in a way, it isn't basic. If you do the training, you can access it at a very superficial level. And it's RCN accredited. I'll get that in. Or if you're interested in knowing more, there are loads and loads of links to a lot more information. So it can be basic so that it will fulfill your needs in your role, or it can be much more complex if you want to know more.
And it is very sort of, it's pragmatic training. It's focused in different areas. So if you're working inpatients, there's inpatient work. If you're community-based, there's information you would need to know there. So it's very tailored as well. And so when we're talking about basic, we're not talking about the diabetes, we're talking about your understanding that you're able to give really good standard of care for people who've come across your doorstep, but also to know when to refer on when something could be a problem, such as someone having an eating issue. Another question, what kind of behaviour will we be looking at in terms of display behaviour for people who are non-verbal? Which is a good question.
It's a good question.
It's a hard question.
Right. Yeah, I can see a thesis. Okay, well, I guess so you're talking about symptoms. Are we talking about symptoms if you were concerned? So I think that would be, so if it would be hypoglycemia, which is a low blood glucose. So let's just talk about this. So we worry about hypoglycemia because it's incredibly distressing to have a hypo. So if somebody was very, very sleepy, snoring very loudly, aggressive, they might experience tingling lips. Now, if someone's got serious mental illness, they may interpret it differently. It's difficult to know, and I'll explain what I mean by that. So high blood glucose, and somebody with high blood glucose may start to lose weight quite quickly, especially if they've got type 1. Or they could be very, very thirsty. You'd see their mouth would be very dry. If someone's mouth is stuck, their tongue is stuck to their mouth, they may have oral candida. You might hear when they talk. Elderly, frail people may not display those symptoms. You may have to really look, they may not be able to tell you, be looking for them. Recurrent infections. So that's the other one. Recurrent infections that if we don't treat the high glucose, we just treat the infection, that just carries on and on. And those patients become a really high risk for acute hospital admission for, all sorts of things, especially during the time of COVID. So those were the patients at the greatest risk, at the peak of COVID. Those sorts of symptoms. And then let's not forget undiagnosed type 2 diabetes, which I haven't mentioned. So, you may, that's why we need to be screening everyone for diabetes. Anyone on antipsychotics is going to be at higher risk. So it's all those sorts of things. And what I haven't mentioned is that people with dementia are also at very high risk of diabetes, and that is also one that has a bidirectional relationship. So people with dementia have an increased risk of type 2 diabetes, and people with all types of diabetes have a higher risk of dementia. So it's about screening both ways. I hope that
this comes down. Oh yeah, that's a good answer. They'll let us know if they want more information, and if we're answering questions of yours and you're still not clear, just say it's not a problem. That's why we're all talking together. There's a couple of other questions coming through as well. Have you any observations on how this issue was impacted by COVID-19 and lockdowns?
Only what I've been told, because I was sort of doing my training, wasn't working clinically at that time. So I know that a lot of people with severe mental illness became very unwell and were treated actually for their physical health in mental health settings. So no, my experience doesn't really extend beyond that. But the issue with COVID is that people are now given steroids, and steroids is one of the risk factors for actually giving someone diabetes if they didn't have it before, and especially if they're already on antipsychotics, or if they have got diabetes, it will push their blood glucose up and can make people very, very sick.
So you're talking about iatrogenic problems then as well. So that's problems that occur because of the treatment or the interventions that we're trying to make to help.
Yes.
Making it worseness.
Well, I mean, in a way, you could argue the same for antipsychotics, but actually,
absolutely.
If someone's severely mentally ill, you have to treat their mental illness. And I think the thing to say about that is there's this big study published in the Lancet about the different types of antipsychotics. And it's the early generations antipsychotics like the clozapine, olanzapines. Those are the ones that really impact the glucose regulatory system. So when your patient is beginning to get better, the good thing to do is to review whether you can reduce their dose and change the type of antipsychotic.
Absolutely. Oh, we're having a load come in now. Oh. Get ready. Get ready.
If I can answer them.
Are people with diabetes classified as disabled?
No, not automatically, not at all. But there are people with diabetes who, as a result of the complications they may have, will definitely be diagnosed. So if you think about the complications of diabetes, they can affect the eyes, the kidneys, the heart, the brain. And it cause neuropathy generally, sort of autonomic neuropathy. So anyone with what we call, I don't know if you know about this, but hypo unawareness. So if somebody has had type 1, especially diabetes for a long time, they may be the opposite of the stereotypical sort of type 1 that we think about in mental health will be somebody who doesn't look after themselves, or they don't look after themselves. But actually the opposite is often true, that people are very anxious, so they over insulinize themselves, they become hypoglycemic, and then they lose their awareness. And if that goes on for a long time, people can actually collapse. It can become a precipitate sort of collapse. So people can be end up actually having, not being able to leave the house because of that. Anyone obviously who becomes visually impaired, and anyone on dialysis, if they haven't yet had a kidney a transplant. And there are other things, autonomic neuropathies, which can mean that people end up having an autonomic, I think that's what it's called, a bladder, where they have to self-catheterize. So there are conditions that lead to a person being disabled. And obviously if they have amputations.
Okay, another question. Can undiagnosed diabetes cause depression and anxiety?
Pressure and anxiety.
Depression.
Well, actually, these are such good questions, because it made me to think.
We're ramping it up tonight.
But it's so interesting. So undiagnosed diabetes, especially, it will be type 2 diabetes, because type 1 diabetes tends to be acute and difficult to not see. So very often type 2 diabetes can have been present in somebody for quite a few years before it's diagnosed, because it can be insidious. But as I said, it depends on the sort of different diabetes, because there are lots of different presentations. But if your blood glucose is gradually creeping up and your insulin levels are dropping because you're not able to make enough insulin, you remember I told you about this guy who became very, very tired because he wasn't injecting. So people can become very, very tired, very lethargic, and that can impact their mood. And in fact, a guy I saw yesterday, it was exactly that he was telling me he didn't want to inject his insulin in public. His blood glucose was high most of the time. He was lethargic, he was depressed. And part of that was because if your blood glucose is very high, not only is it potentially unsafe if you've got type 1 or type 2, but it will mean that it'll be difficult for you to get out of bed. And that in turn will impact your mood. So absolutely, yes.
I've gathered a couple together, which are kind of about money. Though we're facing a cost of living crisis. Are you seeing the impact of this on people's diabetes, and how does this interplay with mental health? And there's another question: do people with diabetes get help with prescription charges in England?
So let me do the second one first. Yes, if you've been diagnosed with any type of diabetes and you've been prescribed any medication, it's absolutely free from that point on. And actually, that brings up a point I wanted to make. I mean, we knock the NHS. You think about America. If you are unlucky enough to have type 1 diabetes in America, you actually have to pay for your insulin. And so people ration their own insulin and end up developing complications. And it costs hundreds and hundreds and hundreds of dollars. So the first question was about the cost
financial
of living,
impact,
the cost of living crisis. I mean, I was in clinic yesterday and I've seen patients who are being threatened with homelessness. So absolutely. And again, if we're working in a sort of multicultural, multi-ethnic sort of a population, we are seeing more of that without a doubt, and people certainly not being able to eat decent foods. So absolutely positive. Positive.
What are the basic things that I can do as a student nurse in terms of awareness and prevention? Things to look out for.
Do the training. Please do the training. And because, it really does talk to everything that you've asked me today. I think be aware of what the symptoms of undiagnosed diabetes are, and the symptoms. You can have a look at the Diabetes UK website. There's a thing called Know Your Risk. And if you've got patients who may not actually be at the level of being diagnosed with diabetes, but maybe what we call pre-diabetic, or the medical term is non-diabetic hyperglycemia. So there's a point at which you don't have diabetes, but your HbA1c, your blood glucose is creeping up. There's a big government drive, and it's called the National Diabetes Prevention Program. Now it was online, but I am not sure whether people, I think that people with serious mental illness and learning disability should have access, but because they are group sessions, sometimes at some point it was an exclusion criteria, which it absolutely shouldn't be. But it's really worth looking at the National Diabetes Prevention Program. If that is an exclusion criteria, then we need to do something about it. If having a severe mental illness. So it's about having access to primary care, to prevention, but also to all of the sort of the surveillance, having an annual foot check, an annual retinal screen, all the prevention stuff, which I have seen doesn't always happen for people with severe mental illness. And I'd say that making sure that your patients have access to all of that, I think, is a really good place to start.
A lot of this is really basic nursing care, isn't it? So having an interest in the person you're working with, being the kind of person they can talk to and share concerns and worries with, knowing what they're eating, drinking, whether they're able to mobilize. I mean, that's, you can't get away from activities of daily living even with that, can you? I should trigger it.
I know a lot of people do worry about eating and diabetes, and I just wanted to say there isn't a diabetic diet. It really doesn't exist. Do have a look at the Diabetes UK website. With type 2 diabetes, it's about healthy eating and about your carbohydrates. And with type 1 diabetes, you can virtually eat what you want. You just inject for the insulin, more or less. yeah, it's people very often get quite cross about that, they think, well, people with diabetes, they sort of cross their arms across their chest and so, shouldn't they be eating a diabetic diet, and very often if someone is having a mental health crisis, it's not going to be able to be your priority to get that right. It's going to be, you can't force somebody to. It's about giving people the healthy choices and trying to guide them to make those healthy choices, and sometimes you're not going to be able to do that at that point.
Got one more question. You've just got in there, oh, Nicky, under the wire before I start to good time's getting away from us. So is it hypoglycemia or hyperglycemia that requires urgent attention?
It's low blood glucose. So if someone is hypoglycemic, that's a blood glucose below 4. If they're at home, so it's important that their family know how to do this, or in a hospital or any setting. Fast-acting glucose, so not anything milk-based. Thank you for asking this question. Not a cup of tea, not a glass of milk. Fast-acting glucose, that could be a small carton of pure fruit juice or a small can of non-diet sugary drink, or it can be sort of glucose tabs, but it's something to drink, or glucogel, 2 sachets into the mouth. No, you would never put anything in anyone's mouth unless they had a safe swallow. If they don't have a safe swallow, or if they're unconscious, you put them in the recovery position, you do 999. There is a thing called glucagon, which is an injection that you might give to somebody if they've got type 1 diabetes, and it's an intramuscular injection. It releases glucose stores from the liver, and it's always either the family member or nurse or doctor would give that. And that buys you time. It doesn't work in everybody. And then there's step 2. So step 2, if somebody's at home, you'd give them a couple of digestive biscuits, a bar of chocolate, and in a hospital as well. So that would be step 2. But the most important thing is, if someone is having hypos, for goodness sake, get somebody to review them. It means they're on too much medication or too much insulin. Very often diabetes is somebody's medication is a dynamic thing. Sometimes it needs to be reduced, sometimes it needs to be increased. It depends on everything else that's happening for that person.
So again, one of the things is just to know the person and to notice changes, particularly unexplained changes, are really useful. Yes,
and nothing is ever static. Things change, and don't just write numbers down. Let somebody know.
Absolutely. So we've got time's getting away from us now. If you could just let us know, what are your plans for the future? What do you hope to see with this work? Because it's so important. Where are you going with it?
So what I really want to do, so I'm looking at the whole patient pathway, and I'm old enough to have worked in loads of places now. So we're in the process of developing. So one of the programs that we have delivered, but it isn't online, is for people working in the homeless services, because there are huge issues there. And so the next step is developing a program, a 4th program or a 5th program, depending how you look at it, for prisons, police services and detention centres. You will know better than I do how many of the people that end up in prison or in police detention centres or detention centres will have severe mental illness as well as diabetes. So there are lots of commonalities, but it's about getting to those services, getting to those staff, and offering that training as a. And I think the other thing to say about the training is some areas of work, and especially care homes, it's about valuing and investing in staff and making them feel that they have a valuable contribution to make. It's not just about saying you've got to do this training.
Yeah. So if you were to leave people with one message, what would that be? I think I know, but tell us.
Listen to the person that lives with diabetes. Listen, to, like you said, think about how it feels to have diabetes, and respect the knowledge they have of their own diabetes. They are the experts of their own diabetes. Be guided by them. And even in the presence of severe mental illness or dementia, we need to listen. If it's not them, their family or their care.
Yeah, just listen harder. Yeah, absolutely.
Yeah.
So thank you very much. And we've got some thank yous coming through. So it's always nice to hear that you found the session useful. Brilliant. And just to say, this training, the links are out on Twitter, and they're also up on Facebook Live. Dave's doing his job, which I'm sure he is. And
if not, I will retweet.
Absolutely. Well, and if you see them, do retweet them as well to your colleagues,
I will
because that'll
do.
be really helpful. So
yeah, everybody retweet, please.
Yeah, everybody. And thank you very much to Ruth for your time, and for the amazing work that you've been doing in this area. It's so valuable. So thank you very much.
Well, thank you for a really enjoyable interview.
Good night, and good night all.
Good night. Thank you, everybody.
Take care. Bye-bye.
Bye. Bye.